Well, all right, guys, so he's ready to come in. So he'll be in just a little bit.
Yeah, just
Okay.
just a numbing medicine for like an hour, and then just have you, before we do the shot, do some exercise that hurts,
Okay.
and then we numb it up, give it 10 minutes, and do it again.
Okay.
And see if it takes away the pain.
All right.
If it's like no difference, then we say, okay, it's back into the shoulder. Because what he doesn't want to do is have you have a surgery on your shoulder, and it doesn't help.
Right.
You know, and the pain's actually coming from, because this is easy, fixing
Got it.
that. The labral thing is more difficult.
Yeah.
All right. So what he wants to do before having a surgery is make sure it's not coming from your AC joint.
Okay.
And so the way we do this all the time is just numb it up and see if it takes away. Because I'm only putting that numbing stuff in that AC joint,
Yeah.
not in the shoulder.
Okay.
Because you had a shoulder shot before,
Yeah.
right? Yeah. So this one's different. It's right up on top there.
Sure.
Does that make sense?
Yeah.
So we use an ultrasound just to mark the joint. So it's just under the skin right there.
Yeah.
So it's pretty easy,
All right.
if that's okay.
It's absolutely fine by
All
me,
right.
buddy.
What type of exercise bothers you the most?
It's normally like a side raise or a front raise, and when I'm putting, like, if I've got dumbbells
Mhm.
and I have to,
Yeah.
lie back onto a
Yeah.
bench,
Yeah.
that is what causes a lot of problem. Like, I used to be able to have my elbows up a little bit higher if I would bench, now I have to have them kind of tucked by
Yeah.
the sides.
Does it bother you to lay on it at night at all?
No.
Okay. And then, so is that an
And
every
like,
time?
like if I'm putting my bag on,
Yeah.
or overhead, putting bags in the overhead,
Yeah, yeah.
just things like that will kind of surprise me.
Yeah. And if I took you next door and had you do some of those right now, it would hurt, do you think?
Yeah.
Okay. So what we'll probably do is numb it up and just take you next door if you can mimic in here or whatever.
Sure.
Because really what we're looking for is, look, every time I do that, it hurts. And if we numb it up, 15 minutes later, does that still hurt?
Yeah.
Does that make sense?
Makes sense.
All right. You want to do it?
Yeah, let's do it.
Okay. I'll grab some stuff. It just takes a second.
All right.
Okay. And then, you can just sit in here and work it in, and then we'll just test it. Okay.
All right.
All right.
Sounds good.
Which arm is it? I should ask. Okay.
Yeah.
All right. So where we do this, I'll have you sit down when we do it, but it'll be right up there on top. Okay.
Okay.
All right. It's just a little joint right there. Okay.
All right.
All right. Okay. Well, I'll grab some stuff. We'll be right back.
All right,
okay?
thank you.
All right, yeah.
So Chris, you can sit right here with your shirt off, okay?
Sure. So is it common, you said, because you call it weightlifter's shoulder?
Yes.
Is it common for weightlifters then to get arthritis in their
That
shoulder
joint.
joints? Yeah.
In their shoulder joints in general, yes, but in particular in that joint. And it's either arthritis where it sort of gets gummed up. There's a little piece of cartilage in there, a little
Yeah.
sliver of cartilage. Sometimes it just, from the constant wear, it wears down and it forms arthritis, so spurs and just gums up the joint. The other condition that happens in weightlifters is called osteolysis of the distal clavicle, or the end of your collarbone, okay, where it gets eaten away. So the joint gets worn down to where the inflammation of the joint then starts to eat away the bone. So you get cysts in the end of the bone, and those hurt also.
Right.
Okay. Those usually hurt a little bit more, and those people usually say, it's right here. That's what, that hurts. Forward raises, bench press,
Yeah.
sleeping on it at night typically, which doesn't bother you.
No.
So those are typical AC joint problems. The
From
AC
weight-
is
from weight
acromion
training.
and clavicle,
Oh.
so AC joint, yeah.
So like for me, for instance, I don't want to give up weight training. I want
Right.
to continue doing what I'm doing. Is there anything that you can do that can kind of help prevent the onset of the arthritis, whether it be
Yeah.
warming up more, whether it be taking some form of supplement, or?
I don't. It's a mechanical stress. So the short answer is I don't think so. It's not put as much load across it, but that's okay. You can change the way you lift, maybe. Okay, so different technique or different positions, but that might be different for different people.
Right.
So I don't know if you can just say, oh, don't do bench press or you'll get weightlifter shoulder, because there's you take 100 people that do benches all day long, and maybe one of them gets this thing.
Right.
So,
Okay.
we see it a lot in the football players because of heavier weights at a young age. We see it a lot in people. The more common cause would be, oh, years ago I landed and jammed my shoulder, and now 5 years later it's starting to wear down.
So that's
the
probably
more
happened to me
common.
because I separated both my AC
Yeah.
joints.
That's the more common scenario.
Right.
And then you just happen to lift also, so that's another chronic stress on the joint.
Got it.
But it was set up from your acute injury where you kind of bruised that cartilage, and now it's compromised a little bit. Then over the miles or the stress, it starts to load,
Yeah.
wear down.
Yeah, got it. Yeah, it's a couple of times something happened there. Once was surfing, I couldn't even drive for like a couple of months.
Yeah.
And the other was a separation with a mountain bike accident.
Yeah. And that may have been really what set that up, if this is the problem. causing your pain.
Right,
And that's
got
really
it.
the question, is this
Got
the
it.
source of your pain?
Right.
And again, I'm not putting this into your shoulder joint, it's only going in the AC joint. So it won't mimic, it won't mask anything that's coming from the labrum and all that.
Gotcha.
Okay.
Well, I got the
Yeah.
tears right.
Okay?
Yeah.
Because where we're putting it is just right in this joint right here, not down here.
Right. Okay. Got
Right.
it.
Okay.
Right at the top.
Yeah. So I'm gonna use the ultrasound just to, because you're a bigger guy. A lot of times we do these blind, we just feel it, you know, we do that all the time, but it's faster and easier if I just mark it and then I just go, it's really
Sure.
easy. So, all right. So I'm just gonna make a little mark on you first, okay?
Mm-hmm.
No shots or anything.
Yeah. So when this accident happened like 2 years ago,
You can
that
see it if you want, but, sorry.
that
Here, I'll-
caused these
sorry.
tears.
Uh-huh.
Yeah.
I wonder
Here's
if.
the joint.
Oh right.
So
Okay.
it's really jagged and ratty. There's also fluid in it, that black hump right there. Okay, so what we do is we just come in right like that. So I'm just using a paper clip here to mark you. Just makes it a little easier. I don't know if you can see that little white thing on top of the screen. It's moving back and forth.
Yeah.
That's the paper clip. So just slide it back. And then, so sorry, you were starting to say something.
No, I was going to say, I was actually performing an exercise that was like bilateral, but I wonder because of these acute injuries on the left-hand side, I wonder if that contributed to the tears just happening in the left-hand side.
Possibly. It might not be that easy to
Yeah.
draw the conclusion, you know?
Yeah.
I'll tell you before I do anything, okay?
Mhm.
So I'm just drawing on you and stuff. Just making a mark again. Sometimes we get lucky and it's right at an intersection where a tattoo or something is, so it's got a nice little mark, but yours is right in between. So you'll feel a cold spray on your shoulder, okay, that just numbs up the skin.
Mm-hmm.
And then a little shot here, okay?
Mm-hmm.
All right, cold spray. Sorry. Doing okay?
Mm-hmm. Yeah.
Still good?
So far, so good.
Feel some pressure probably. You okay?
Yeah.
All right, that's it.
That's simple and easy.
Okay, put a little Band-Aid on you. Then feel free to move it around, work it in there, and then if we gotta take you next door to try some lifts, or you can mimic it in here, whatever, you know,
Okay.
just feel free to test it out.
All right, yeah,
Give it
I'll
about
have
5,
to,
10
I'll
minutes.
have to go next door.
Yeah, yeah, and you can just wait, and Dr. Lewis will probably come talk to you, and, you know, let you guys decide from there, okay?
All right,
All right.
that's good. All right, thank you, sir.
Pleasure, okay?
Appreciate
Yeah,
it.
good luck, okay?
Thank you.
Yes, it is gonna go underneath around here. I'm just gonna put that like so. This is going around your waist. This is where I feel like a flight attendant when I say you should tighten it low and tight across your wrist. Okay, and your forearm goes in here. Good. Ooh, that's ginormous. Let's go get a medium. Much better. Okay, just rest it there. Good. So go ahead and bend this elbow and push back like you're putting a backpack on. Good. And reach forward through here without getting caught on your bracelet. Good.
Am I like, because of the surgery, am I likely to have someone put this on for me?
You know what? That's a really good question. Most people, now that it's all stuck together, it's a lot easier to put on yourself. You're right-handed?
Yeah.
Yeah, so you'll do fine with the clips, but that is a good question. Because at first, it just takes a little getting used to. So what you should do is practice now before surgery, so you just kind of have a better idea as to how to put it on and off, okay?
Yeah.
And like I said, I make it look more complicated too, because I'm taking it completely apart. Alright, Kris, so when you wake up from surgery, your arm is going to be numb, and it's the weirdest feeling. It just kind of flops around. So when you wake up, you're already going to be in your sling. This strap here is going to be in the front of your thumb, so your arm doesn't slide out.
Right.
This strap here is going to be like so, so your arm doesn't pop out. Once that numbness wears off, you don't have to use these straps anymore. You can take them off and get rid of them if you want.
Okay.
Okay? I'm just going to take them off from now, so it's easier for them to put it on in surgery. This is, just like a squeezy ball. You can leave it attached to your sling here, and it is a good idea to use it. The more you pump your hand, the more it helps control some of the swelling that might occur in your lower arm.
Okay, at what point do I start using
You
this?
can start it that night if you want to.
Okay.
But
alright.
usually the next day, because it's going to be numb anyway.
Yeah.
I mean, you'll be able to move your fingers, but there's no real right or wrong to it. It's just every once in a while if you're pumping your fingers, that just helps with the flow a little bit.
Okay.
Better. So now, when you take it on and off, all you're going to do is unclick the 3 snaps in the front. Slip this off like a backpack and let it drop to your side. And then most people, what they do is kind of lean over onto a counter, like so.
And drop it
Yep,
down.
and drop it down.
Got it.
Exactly.
Alright, perfect.
Okay?
Still got some discomfort there. I've still got a bit of discomfort there.
Really?
Yeah.
So if you had to give it a percentage, is there any relief at all?
Let me give it another shot.
It's usually a pretty telltale sign, like you usually have a lot of relief done.
I'd say it's probably about 50%
50%?
relief.
Okay.
Yeah.
Okay, good. That'll give them some info.
Okay.
All right, you guys.
Can I just
All right.
try a couple of
Absolutely.
others
Yep.
just out of
Yep.
interest?
Yep. No, I didn't see that at all.
Yeah, it's the same.
Same?
It's about 40-50% relief. Yeah, I can still feel it there, though. You know.
Yeah, we've given it enough time, so we would know.
So if the injection did not give you 100% relief, then that's not the sole source of your discomfort.
Right.
Okay, so I wanted to do that though because your X-ray clearly shows abnormalities of your AC joint. Typical if somebody's injured it before.
Yeah, that's
and
me.
typical of people who lift weights. Okay,
Yeah.
that joint begins to kind of deteriorate over time, and so and your X-rays show that, and the MRI scan shows that, and Dr. Shuffle mentioned when he looked at it with the ultrasound, there was a lot of fluid around the joint. So there's probably some element of that joint being a problem for you.
Yeah.
And I kind of wanted to know that going into surgery to decide whether or not we should consider addressing that joint
Yeah.
while we're in surgery.
Yeah. Well,
so-
I'd say it was alleviated by about 40 to 50%,
All right. So.
but not 100.
Okay, so the worry would be that if the other abnormalities in your shoulder are causing your pain, and they're only causing 50% of it, but it's causing 50% of your pain, that we could remedy those, and you'll still have pain from your AC joint.
Yeah.
So, I guess the question is whether we ought to proceed and address the AC joint as well as the other abnormalities.
Mm.
Now, most of the time we don't look at surgery for the AC joint is that worrisome. Most people do very well when you take care of that problem. But everything we do to your shoulder has potential consequences. So we don't want to do something that might make you worse.
Yeah.
And in somebody who's a high demand athlete, when it comes to their shoulder, there's always abnormalities that we see on the MRI scan, and always abnormalities we see at the time of arthroscopy. And it doesn't necessarily mean that those are problems.
Yeah.
So sometimes we're better off leaving certain things alone. And
Yeah, for sure. Because when I separated my AC joints, quite a number of years ago, luckily after a couple of months, it felt okay-ish. So they at the time they said, well, there's no need for us to shave your clavicle joints, whatever. So from that point onwards, I just did exercises that didn't aggravate it.
Okay.
And I was fine with it. Yeah.
Well, what do you think about that? Do you think it's worth looking at shaving the end of that bone off?
Well, if you think it could possibly help me in the long run, like at the moment, I don't know, maybe I could deal with it.
Mm-hmm.
But like I'm looking to the future, like is this arthritis going to get worse? Because I'm going to continue doing what I'm doing.
Right.
And if it can help with that, sure.
Well, it almost assuredly will get worse. Okay. And usually, as time goes on, the wear and tear, the deterioration at the end of the joint continues to progress. And with the activities that you do, those are activities that are going to make it progress.
Yeah.
So I think that in the future, I think there's some value in addressing that while we're there. Okay. I mean, you're going to be under an anesthetic. You're going to be undergoing surgeries that are going to actually be more of a recovery. There's going to be more rehabilitation with what we're planning to do than the AC joint. That's almost just kind of a side type of thing. I mean, you'll be recovered from that before you're recovered from all the other things.
Right, okay.
So I think that there's, and the one thing I would hate is you go through a big operation, you take months to recover, and as soon as you start back into it, 50% of your pain is still there.
Yeah.
Okay,
Yeah.
and you go, oh, we should have done something about that at that time.
Yeah.
And we've been in that situation before where we do this stuff and people come back and a year later we're operating on the AC joint, and we should have just done that at the same
Yeah,
time. So,
okay, that makes sense.
So I think that addressing that while we're there is a reasonable thing to do.
Okay.
Based on the fact you got 40 to 50% of relief from the injection. If you had no relief at all from the injection, we shouldn't be considering doing anything to the AC joint. But the fact it gave you some relief, I think that there's reason to proceed with doing it's called a distal clavicle excision, where you kind of shave off the end of the collarbone, basically.
Okay.
So, okay. All right. So, well, stand up here for me if you would, and I'm going to have you face away from me. And it's actually fairly clear, even feeling your AC joint, that even this AC joint doesn't feel totally normal.
No, because I separated both of them at the same time. I went head first over a mountain bike.
Does that bother you when I do that?
Yeah, a little.
Okay. If I come across like that, not too bad?
No, it's not too bad.
Okay.
Not as bad as the other movie.
And right now, I don't expect that to be very tender. We've anesthetized it.
Yeah.
Okay, so
It's tender.
that's where you don't like it, right?
Yeah.
Okay. All right. So, okay. All right. Hold your arm straight like that, and don't let me push it down. Don't let me pull it back like that. Okay. All right. Hold your arm kind of like this, and don't let me pull it down now. Does that bother you when I do that?
No, it's not so bad.
All right. Okay. All right, you can have a seat. Okay. Let me ask you a few questions.
Yeah,
Okay?
sure.
You can ask me whatever you need to ask me. I've been over this before already. So you've never had surgery before?
Never.
Right? Okay. And no chronic medical illnesses at all?
No.
Yeah. You're not taking any prescribed medication?
Yeah.
And you're not allergic to any medicines, right?
Nothing.
Okay. No chronic bleeding or clotting disorders in members of your family or any chronic medical illnesses?
No.
Do you smoke?
No.
Okay. And how much alcohol a week would you say you drink?
A week? Oh, no, it'd be like every few months.
Okay, all right. Okay. What questions do you have of me?
So the rehab, what does a rehab look like after this?
So basically, again, what we're planning, or what we expect to see, based on your history and your exam, is it looks like you have a small rotator cuff tear, and it looks like your posterior labrum is torn. Okay, so we'll be repairing those. Now, the early part of the post-operative period is getting that to heal. Okay, and so that requires not stressing the repair, and that's the purpose of that sling that we're going to put you in. And now there's value in keeping in the sling for an extended period of time to make sure that the healing is adequate.
Yeah.
But there are problems with keeping the sling too long, and it makes your shoulder too stiff, and then you struggle with your rehab afterwards, just trying to get over the tightness of the shoulder. So we'll plan to keep in the sling for probably about 3 to 4 weeks. If the posterior labral tear is fairly extensive, then I'm going to keep you in the sling for probably 6 weeks.
Okay.
Okay. Now, in the sling, there are some things you can be doing in the sling that are not going to stress the labral repair.
Yeah.
Primarily some isometric type things.
Okay.
Some with regards to the posterior labrum, the way that gets stressed is with motion kind of across your body,
Yeah.
or motion that pushes back like this on the shoulder.
Sure.
So we're going to want to limit those things, but we can do things within that range, within those ranges of motion.
Okay, just
But-
like external.
But a lot,
internal.
yeah, just little minimal things. Now, at the same time, if we repair your rotator cuff, as you tighten up your supraspinatus tendon, which is the one that appears to be torn, that's going to pull on a repair, and we don't want to pull that apart. And we know that process probably takes close to 3 months for that tendon to be maximally healed into back down to the bone, where it's detaching. All right.
Okay.
So, however, the way we repair it, it's a pretty strong construct of sutures and these suture anchors that we put in there to hold it down. So it can be stressed to a point for those first 3 months, but not excessively. But in general, what it is for really very little of anything for the first 3 to 4 weeks.
Yeah.
And then we start doing what we call some active assisted exercises, where we start getting you moving your shoulder, but with help. So
Yeah.
that's either with a pulley, a cane, or a dowel like this to help you, using your other arm to help move it around,
Yeah.
or have the therapist help move it with
Okay.
you. Okay. So that's generally from between 3 and 6 weeks we do what's called active assisted motion. Now, between 6 and 9 weeks, then we start doing more active motion to try and start engaging the muscles and trying doing things with good rhythm and staying in kind of good control, very controlled motions, with just active motion where you're initiating it just with that shoulder without help. At about 9 weeks afterwards, then we start doing some what we call progressive resistive exercises, where you start doing things against resistance, starting light and moving up heavy.
Okay.
But it's not, we don't want to start pushing this hard until you're 3 months out.
Yeah. Okay.
As far as
So I couldn't even really basically attempt swimming until about 3
no.
months.
So,
Okay.
so
Ah.
yeah, there's some value in the pool of doing some kind of more gliding type exercises in the early stages to help work on motion, where you just kind of push off and let the weight of let your body weight float in the water and let the water kind of lift you up a little bit. But that's not a cardiovascular exercise.
No,
Okay,
okay.
it's almost a soothing exercise. Okay, so, but yeah, you're not going to be doing that until you're 3 months out.
Okay.
Okay,
All
all
right.
right. So that's what's it. And you're not going to really be doing a lot of big lifts until you're, probably close to 4 months out.
Yeah, that's fine.
Yeah.
But I'll be able to train other body parts.
Oh, yeah.
Yeah.
And there's a lot of lower body stuff to do. There's a lot of core stuff to do.
Yeah.
Even in this sling, and there's a lot of, you can work the other arm.
Yeah.
You know, there's a cross, you know, there's a crossover where, you know, you can maintain some bulk of the injured or immobilized extremity by working the other arm.
Yeah.
So even doing some dumbbell things with the other arm. Of course, it means being in good position.
Yeah.
And by being down like this, you lose a little bit of your, you know, weights and balances kind of thing.
Symmetry. But
right.
you're saying that you could possibly prevent some of the atrophy from the arm
Yes,
by training other body
Right,
parts.
yes, for sure.
Interesting.
Yeah, we know that. You know, we've known that for decades. That if somebody's immobilized in a cast, for instance, if they work the other extremity out, the contralateral extremity out, that they'll have less atrophy of the totally immobilized.
Is that something to do with the fascia, because the fascia is all connected? Because I know, like, if people are, for instance, doing like a kettlebell, or they're punching with that one arm, if they squeeze the other hand, it forces more force through the opposing.
Possibly. I think a lot of the fascial connections, to me, this is a fascinating kind of new train of thought, is the cross link of the fascia. So if you look at for instance Rolfing, for instance, and you look at if you look at the you know when Dr. Rolf first he has all these cross connections of fascia that kind of go from one side to the other, and I think we're learning very clearly that there's a definite effect of all these fascial planes up and down the whole body, from, you know, the top of the head to the bottom of the toes, and so whether that's part of it, whether the traditional thought has been that by working one side, that the neuromuscular connection, it keeps the other side somewhat engaged.
Right, okay.
So the thought has been it's more of a neuromuscular thing. In other words, you're working one side, but the brain is now staying at least somewhat involved.
Yeah.
And so the other side is seeing some of the neurologic input to the other side, even though it's being held still.
Okay.
I think that's been the traditional thought, but I do think a lot of this kind of cross reaction with all the fascial planes, and a lot of these fascial plane issues go back to a lot of traditional, you know, Chinese or Ayurvedic medicine, which have been studied for a lot longer than our Western medicine. Okay, and I think they've known things for centuries or millennials that we don't know. Okay, and now we're learning that a lot of those things have value. We've kind of been, I think, somewhat dismissive of that by calling it alternative medicine. But the fact of the matter is, it's all whole medicine. I mean, they've learned things we've kind of dismissed,
Yeah.
and now we're realizing there's value to that.
Yeah.
And I think a lot of this fascial work is really fascinating.
Yeah.
And there's a anatomist in Italy who has written a great, well, his daughter's an orthopedic surgeon, his son's an orthopedic surgeon, and they've written some really excellent fascial anatomy books. They're really great, showing all these fascial planes intersecting. And I think we're learning more and more about the fascia being an issue, and that's where I think Rolfing comes into, and certain types of massage, and whether it's acupuncture or dry needling, all that's kind of designed to kind of stimulate the fascia. So there may very well be a fascial connection there.
Possibly, yeah. And before, like, I'm able to get into resistance training, do you suggest or recommend any of, like, the pads that you get kind of for addict, where they can involuntary contract your muscles?
You mean with electrical stimulation,
Yeah.
type thing? Yeah, well, frankly, I think all those are helpful. All right,
Okay.
now, how do they work? I think we don't totally understand. I mean, there's some suggestion that, by electrically stimulating the muscle, that keeps the motor implates functional. All right, and so you continue to see some muscle activity, which creates hypertrophy.
Yeah.
By just even with rest
Yeah.
So I have no problem with that, frankly, and so
do it.
if people are interested in trying that, I'm fine with that.
Okay.
And look, we like those things, okay, and it's just a matter of whether people have the resources or the ability or the time to take advantage of that.
Yeah, yeah,
so,
for sure.
So I'd be all, I mean, I'd
Well,
be all about
there's a
that.
person that's a specialist in it in Texas,
Mhm.
and I know he's coming up next weekend for the Boise Fit Expo.
Okay, all right.
So I was interested in talking
So,
to him about
yeah, I mean, so look, you know, we base a lot of things in standard Western medicine on all this kind of evidence-based kind of data,
Yeah.
you know. So you have, 50 people, 25 this, 25 that, does it work or does it not?
Yeah.
But I have a lot of skepticism over a lot of the evidence-based type of activities because every athlete is their own, what we call an N of one. They're their own subject. And comparing you to somebody who else I do the same operation on that either is not athletic or is a different type of athlete, it's hard to compare those two people based on what their expectations are or the results are afterwards. And so until we try all these, what have traditionally I think been called alternative medical treatments, until we've tried them on enough people and seen see how they do, we don't really know whether they work or not, right? And there's a lot of data behind why they might work, but we don't know how that corresponds to the actual final outcome.
Right.
So,
Okay.
and so, and people that are, what our goal is that from a standpoint of getting you better, all right? There's the technical aspect of doing the right operation for you. Okay, and that was the purpose of doing the injection to see if that is how important that is to the whole issue of your pain. So we want to technically do the proper operation and do it properly. And then we know about the kind of biology of how things heal and how long they usually take to heal.
Yeah.
And so we want to be aware of that and make sure that we let things heal properly. Okay. So we feel 50% of the success of the surgery is that aspect, but the other 50% is you rehabbing it properly. Okay. And we don't want to throw you into starting to do big lifts before we've rehabbed all the little muscles that are just as important.
Yeah.
Okay. You sent an email out a couple weeks ago talking about that, about the rotator cuff and some of the lifts. And I thought that was a good email. I mean, I thought that hit things right on the head about working out these other things, these other smaller muscles that you don't necessarily see.
Yeah.
Okay. And I think that's crucial. Shoulder's a very complicated joint. Okay. So even if you look at this AC joint thing, even if that's not your problem, but you're feeling discomfort with that when you're doing some of your lifts. So there's certain lifts where you get to a certain point where that's about to hurt, and you've learned that over time, so you just rotate something a little bit, or you drop your shoulder blade down, or let it lift up a little bit. And then that then throws extra stress on the next cog of the wheel, basically. So everything in the shoulder has to be working in synchronicity, and there's all these muscles that are pulling, there are muscles that are pushing, and then there are muscles that as one muscle contracts, the muscles behind are kind of letting, they're contracting too, but kind of letting things, they're contracting in an eccentric way, where the other one's contracting in a concentric way. And so, and I tell people it's like belaying down a cliff, okay? And you're letting your body weight and your strength kind of take you down the cliff, but if the person holding you just lets go, disaster strikes.
Yeah.
And so the same is true if you're building up something that's in a concentric way where you're expecting an explosion this way. If the one behind isn't kind of letting it go in a controlled way, this sudden movement this way is going to pull on something else and potentially tear it.
Yeah.
And over time, you get repetitive kind of stress, and it begins to break down.
Yeah.
Okay? So we see that in a lot of shoulder issues, especially in throwing athletes, where they've developed all the stuff that makes them go forward, but they haven't developed the stuff that's kind of controlling it from behind. Okay, you get that stronger, and they often get better. Okay, unless they've already had a breakdown of the tendon or the ligament. So, so those are all things that we are going to be really important in recovery, as everything's working in synchronicity before we start hurling you back into big lifts. So, okay, that makes sense, kind of thing.
Yeah, it makes perfect sense.
All right, so that's going to be kind of the goal of your therapy afterwards.
Yeah.
So a lot of little things before you start into the bigger things.
Yeah, of course. Yeah, it makes complete sense.
So,
Yeah, I was kind of expecting that.
So.
Do you think it's setting clear expectations for him to be able to be at this expo on Saturday, with the Thursday being the surgery day?
As far as like just being there,
Yeah, it's just going to be behind a booth.
yeah, you ought to be okay with that.
I'm fine with it.
It's going to be uncomfortable. Okay, I don't know whether you want to take any pain medicine or not. Before you go. Look, most people are hurting for the first couple of days where it's uncomfortable.
Yeah, maybe I don't have to be there all day. Maybe I can just.
I
have a
think
few
that's
hours.
I think that's what you would find is you'll get tired. You'll get there and go, oh, I
Is
need.
that
I need
because
Yeah.
of the pain meds and the nausea?
Part of it's
meds?
that, and plus it's hard on you. Okay, I mean, and we've kind of tightened some things up, and so people tend to kind of they tend to kind of they're somewhat, even if they're not hurting that much, they tend to be somewhat protective, but so they're kind of in a constant state of being in an isometric contraction, and that just gets fatiguing after a while. This is all getting tight up here, and your pec is getting tight, and your lats and your traps, because you're just jammed like that. Now, if you could, what the purpose of the sling is so that you just kind of relax,
Yeah.
and it's just kind of, and you find the spot. Look, she's fit that for you, but you play around with that. If you feel that this pad needs to be underneath you more, or if you want to be out further on the pad, or you want it back like this or forward like this, you find the spot that's most comfortable for you. So you can kind of, and just try and get all this stuff to kind of relax.
Yeah.
Okay. So it's all this trap stuff in the pec being kind of like this, because it hurts, and you're trying to protect it, and after a while, that gets tiresome, and all this stuff starts to hurt in here.
Yeah.
I mean, when people come in and say I'm hurting, when you start poking on them, where the hurt is, up like in their pec minor in here, you have their trap back in here, and kind of up here in their trap up in here from just being jammed like that because they're just anxious, and they feel they're more protected that way.
Yeah.
So
I'll just do like maybe a couple of hours in the morning and an hour in the afternoon or something.
Yeah, that's what I think would be good.
Yeah.
But yeah, you just don't want to go too crazy, just because it's make an appearance to be good, and then
Yeah.
try to heal as fast as possible, right?
Sure. But I could potentially, like, the following day, get on my exercise bike and.
yeah, first of all, you're welcome to do that as soon as you want.
Yeah.
Okay? The night of surgery, hopefully this block that's in your shoulder is going to keep you very comfortable for the first night. Okay, but when that wears off is when it tends to hurt. Now, look, I had my rotator cuff fixed. I took pain pills that first night. I was waiting for the onslaught of the pain because everybody would say how much it hurt, and I never took another pain pill again. It wasn't that bad. Okay, but everybody's different. And so just because that's the way I was doesn't mean it's going to be that way for you or anybody else. So,
Yeah.
so I mean, I think if you're, not overly, I think what a lot of people do is they get very anxious, and they feel bound down in this thing and feel like I kind of need to do this, and I don't want you doing it. You can bend and straighten your elbow, okay, but I don't want you doing all this.
Yeah. Okay. All right. Yeah, I'm kind of expecting a worse, so I shouldn't be anxious.
All right, so yeah, I mean, I think you'll be fine that next day, and I think getting on the stationary bike is fine.
Cool.
And you can start doing leg stuff as soon as you feel comfortable. Now,
Perfect.
make sure if you're doing, especially body weight stuff, you've lost this limb.
Yeah, that's fine. I'll be in machines.
Okay,
mostly.
machines you'll be able to tolerate machines.
Yeah.
And I'd start doing some things on the other side. And you can do even some, you can do some dumbbell cleans on the other side if you feel stable, So kind of, so you can be doing stuff on the other side right away. And like I said, there's a crossover there there's an article in the New York Times about that last week, about, if you're mobilized on one side, lifting weights on the other side. So
Okay.
the New York Times is a,
Yeah.
but those articles they write in the New York Times are based on studies that have just been published usually.
Right.
So they have a science editor who reads all that stuff, so.
All right.
So, yeah. So there's value doing that. So.
Okay. One other thing I was going to say is because I've gone over like that ice therapy.
Mhm.
I do have an infrared sauna at home.
Mhm.
At what point would I be eligible to use that?
You can use that as soon as you want.
Oh, really? Okay.
Yeah, as far as the infrared sauna, I know there's a lot of, interest that the infrared sauna, particularly more than a wet sauna or something, has certain healing values and so
Penetrates
forth.
a little bit deeper, yeah.
So you can use that as soon as you want. I mean, like, you know, we, next door, we'll use lasers on people right away and so forth, as far as trying to improve healing and so forth, so.
Alright.
And, you know, again, that's all stuff where the data is somewhat out, but enough people swear by it that there's probably some value to it, you know, so. We just don't know exactly what it is. So.
Yeah.
But you can use infrared sauna as soon as you want to.
Great.
So, look, the cold therapy, the ice therapy, that's also highly controversial, okay? And so, and probably the cold therapy works, I mean, the way we've thought it worked traditionally is the cold itself is a bit of it has some anesthetic properties, by just numbing the skin up, people tend not to hurt as much in that rest of that whole dermatome, all right? And also, when you take cold off, there's this reflex kind of influx of blood. That's why your skin then turns red. And the thought is that maybe that brings more blood in as a healing factor. But there's also a lot of data out there that shows maybe ice is not that helpful, okay, or not any more helpful than no ice as far as recovery goes and so forth. But again, enough people swear by ice that I think there's value in using it.
Yeah.
And I can tell you that cold unit, like right after surgery, okay, and that for the first several days makes a huge difference in people's use of narcotics. Okay,
Yeah.
They use that, they don't need nearly the pain medicine. So,
And whilst on that subject, I do have access as well to a cryotherapy unit as well, Dr. Jason Watson.
yeah, I don't have a problem with that either. So,
Okay. What about pulse magnetic field therapy, PEM?
Well, I think, again, I don't think I think that would be fine. And even as soon as you want to start that, I'm okay with that. Okay. So,
All right, perfect.
So, and you know, from the healing standpoint, there's reasons why that might be helpful in accelerating the healing process, as well as kind of reducing swelling. So,
Right.
there's really, I think it's highly unlikely that would retard the healing.
Yeah.
So none of those things I'm worried is gonna cause the healing to slow down.
Yeah.
So, okay.
Yeah, okay. All right, perfect. Thank you.
So, I mean, you can throw all that you want, if you have access to it,
Yeah.
I'd say go for it, so.
Okay. All right, we'll give it a shot.
I mean, we've used that stuff all the time, if people had access to it.